Good morning. Welcome back. It's been a day and a half of very rich discussions, so we're hoping that this panel will try and wrap together the various different topics that we've discussed, focusing particularly on how we can identify the roles of different stakeholders and harness stakeholder capacities to address some of the challenges that have been brought up. So we're going to do this a little bit differently. We'll have the panelists, our very seasoned experts here, give some brief remarks in the beginning and do more of a discussion format, and then open it up for questions a bit later. So I'll start with Dr. Mona Saraiya. I'm not going to go into the detailed bios because you have bios, but Mona is, she is medical officer at CDC and also the associate director of the Division of Cancer Prevention and Control at CDC.
Okay, just to clarify, I'm Associate Director of the Office of International Cancer Control. Thanks for the opportunity to provide some perspective from the CDC. So as we mentioned yesterday, we both have a domestic as well as a small global mandate working, and one of the things I wanted to highlight after hearing the last few days is that I do think that some of the territories and the regions that the U.S. work in are very global in nature, and specifically I wanted to speak a little bit about the islands, the U.S. Pacific Islands as well as the U.S. Virgin Islands, because they are very geographically dispersed and there needs to be, and they don't have much of a voice because of the small number and burden of a variety of cancers, chronic diseases, and specifically in cervical cancer, as I mentioned to you, we had to do a roundabout in terms of trying to even think about self-collection of HPV, promoting VIA or HPV testing when that wasn't FDA approved, or even if we want a point-of-care test for HPV, we have to go through the U.S. organizations rather when there's already a World Health Organization policy to consider these kind of technological advances. Similarly, for breast cancer screening, they have a mammography machine in an island, but they're not able to use it. It's not being used. How can we think about innovative ways to reach these populations? I mentioned the U.S. Pacific Islands and Virgin Islands, but there are, areas that Isabella mentioned as well, the Deep South, Appalachia, the U.S.-Mexico border. So some considerations in terms of how some of the global strategies can be used there. And also synergies with other Pacific Islands or Caribbean islands. They're going through the same kind of issues, and could there be somewhat of a regional approach, not just the U.S. government, but other bilateral groups that have a presence there, whether it's France, Denmark, et cetera. And similarly, the immigration issues, or thinking about some of the burden in the U.S. populations that are immigrants, recent or past, if there's a way that we can capture the treatment patterns as well as the surveillance of U.S. Foreign-born folks in the U.S. to see if we can improve their cancer care, cancer treatment as well. In terms of lessons learned, I think we spoke a little bit about organized systems and trying to see if, we've learned a lot from the U.S. in terms of not having an organized screening and opportunistic screening. We're doing annual screening. Is there a way that we can sort of promote the organized approaches for cancer screening from lessons learned that we've learned from Europe as well as other countries in terms of putting an emphasis on organized screening when we go into the country, whether it's all U.S. government players playing more of a cohesive role, as well as private and public sectors thinking about a more comprehensive approach for cancer screening. I wanted to speak a little bit about, Ben didn't speak, but Lisa spoke about resource-appropriate care. So that goes hand in hand with the organized screening. What is appropriate? But we need to be careful to interpret that correctly, because we're not saying that we want to ultimately reach what's occurring in the high-income countries, because that's not always the answer. So we have to think about, is it evidence-based and is it acceptable? And being in the non-communicable disease group, I just wanted to see if we can package interventions a little bit more. When we're thinking about cancer, there's cancer screening and other cancers, but there's also the opportunity with primary care to think about the other risk factor reductions and what primary care role can play rather than having a siloed approach. And last but not least, surveillance is key, is dear to my heart. And I think we need to think about surveillance in a little bit more systematic fashion, whether it's cancer registries, leveraging other registries to collect cancer, and then thinking about registries for screening as well. Thinking about screening registries, how could they be collected? Is it possible to collect diabetes, hypertension, as well as screening registries, and ultimately link registries to outcomes? So strengthening both vital statistics as well as incidence-based registries.
Thank you, Mona. Our next panelist is Dr. Ted Trimble, who is the director of the Center of Global Health at NCI. I think he'll be touching on various topics, but I'm hoping that he'll specifically also comment on how public-private partnerships currently function in low-resource settings and how they might optimally function in these settings.
Well, I guess I wanted to start by emphasizing the importance of public-public partnerships, because as we've heard, I think it's time that we unleash the full power of USAID and CDC on cancer and NCDs. And so I think we have to figure out how best to do that. And I was talking with Sally Cowell and Paul Holmes of American Cancer Society on this topic, and I think it's a critical one. I think in terms of public-private partnerships, this is something that we obviously work closely with our universities. We work closely with other countries. We're delighted that Ambassador Castilla will be here, because I think we've got some great partnerships through his help with our friends in Peru. So we know it's that no one institution can tackle this issue. Some specific things I did want to follow up on. Mona talked about the importance of registries. I think we need to make sure that our cancer registries are linked to the vital registries, the death registries, that we work with countries to help them set up unique personal identifier numbers. We don't do a very good job in this country of tracking people, so we can link databases. But in these days and times of biometrics, of mobile phones, I don't think we can. It's not acceptable that anyone is lost to follow-up. So I think we need to make sure that we can link these databases. One of the things I was, proud of as yesterday and today was hearing about the great research that many of the people in this room have done with support from NIH and NCI. So I think it's clear that there has been a commitment to tackle the issue of health disparities as well as implementation science. We're trying to expand those opportunities, but we are rewriting the NIH-wide implementation science program announcement so as to make clear that global health studies are of great value to NIH and NCI. I also wanted to mention briefly that we were able to get support from our Board of Scientific Advisors for a major commitment to validation studies of novel technology. Kathleen Schmieler is here, is one of the recipients of these awards, but this is a commitment of somewhere between $30 to $50 million over 5 to 7 years to validate new technologies. And another example of a public-private partnership, because we require that the applications come in with partnership between people with expertise in global health, in cancer, in engineering, and business, because we want to make sure that the products that are developed are ready to be, if they're found to be effective, are ready to be marketed at low cost. The last thing I wanted to mention is, how we've been bowled over by what U.S. cancer centers are doing globally, and we've been trying to figure out how we can help them strengthen their activities, to develop a career track for young investigators, to expand the work of senior investigators in mentoring. You've heard about some of our cancer center supplements, in terms of the research that they've supported. And we have an RFA currently on the street to build consortia of cancer centers, both from the U.S. and other high and middle income countries, to work together in a country or a region. So we'd be happy to talk to you more about that, but we think that's an exciting approach. We've also designed it so that it includes other NCDs. It can include surgery, it can include road trauma, it can include snake bites, it can include hypertension, diabetes. Because we think it's important for people to work, to break down the silos and people to work together. Thank you.
Thank you, Dr. Trimble. We'll have Dr. Otis Brawley come up next, going to the podium. Dr. Brawley is the Chief Medical Officer at ACS, and I hope he'll add a bit more on perspective from NGOs, particularly ACS.
Thank you. I'm a medical oncologist and epidemiologist, very interested in cancer in low and middle income countries. These are my disclosures. Most importantly, I published a book a couple of years ago, and some of the things I'm going to say in the next 3 minutes or so are themes from the book. They have to do with rational healthcare versus rationing of healthcare and the need to prioritize cancer control interventions. The American Cancer Society, very briefly, is involved in some global efforts in tobacco control, pain control, capacity building. When I say capacity building, I'm talking about medical capacity building, training the press to actually portray cancer control messages adequately, and training political leadership to understand the cancer problem. Cancer, of course, is an important health issue in low and middle income countries as it is in upper income countries. In Africa, for example, it kills more people in malaria, tuberculosis, and HIV combined. Cancer control is traditionally described as interventions to reduce morbidity and mortality from cancer. It can involve screening, controlling exposures to carcinogens, behavioral changes such as smoking cessation, diet modification, and weight control. It often involves public education, and these messages, as we've heard over the last 2 days or day and a half, need to be tailored. I want to note that they really need to be highly scrutinized for accuracy and for importance. I've seen cancer control messaging through lay press, through politicians, through celebrities, and through public health officials. I've seen messaging that sometimes was just wrong, inappropriate for the community, diverting precious resources away from where they can have the most impact. We've seen countries advocate prostate cancer screening when there were no urologists in the country capable of treating prostate cancer screening, and no radiation oncologists capable of treating prostate cancer. We have seen advocacy for breast cancer screening deliver mammography equipment to countries that had no one trained to actually use the mammography equipment, or we haven't even gotten to the point of no one trained to actually treat breast cancer. And so we need to be a little bit better in prioritizing our messages and prioritizing our charities. I'm especially attuned, even in this country, that messaging for healthcare is kind of like sending information down a T1 line in the internet. Those of you who still have DSL, if you send messages down that line that are wrong, or that are off base, or that are inappropriate, you dilute messages that actually are appropriate. You decrease the impact of messages that need to get through to the population. So I'm just making a call that we be very careful and that we prioritize our messages, do very careful cancer control planning, apply scientific orthodoxy, and be very careful about communicating the truth, and the truth that people actually need to hear. Thank you.
Thank you, Dr. Brawley. We'll have Loyce, Dr. Ambassador Castilla, welcome. Perhaps we'll have you comment next then. Ambassador Castilla is the ambassador of Peru to the United States, and he was a former Minister of Finance and Economy in Peru, and I hope he'll comment a bit on how Peru has addressed affordability of care.
Great. Thank you very much. Sorry for the delay. in coming here. First of all, it's an honor to be invited to this important seminar. You may be wondering why an ambassador is here. And actually, I'm going to talk to you about my country's experience, given my past background in terms of policies towards cancer prevention, cancer attention, in a country such as Peru, that you may not know, we're a country of 30 million people, more or less. We're a middle-income country. Our GDP per capita is around $10,000 a year. We've been a fast-growing economy. We've reduced poverty in the past decade from over 50% to around 20%. And we've been investing heavily on human capital, education, health. So let me, that's a background on the country, and let me now go into our own experience from the point of view of the policymaker, and in particular from the Treasury, from the finance part. That is, I think, quite important to sustain any efforts towards policies geared towards early prevention, early detection, early detection, treatment of such a disease. We in Peru, our health care insurance more or less covers 2/3 of the population. That means that we have 10 million people without any access to any sort of insurance, private or public. So 10 million people, and we have a growing trend of recurrence of cancer cases, around 50,000 a year. And it's becoming an ever higher, trend, positive trend of newer cases. So in Peru, obviously, as in many emerging economies, developing economies, we realize that this is a disease that has displaced other diseases, and it's becoming a #1 priority by different governments. The efforts actually began 10 years ago when Peru created its own first national cancer control plan in 2005. There was an agreement, there was support from friends from all over the world, from the National Cancer Institute, among them, and other international institutions. But there was an actor that was missing, which was the finance ministry. And this didn't go beyond really good wish. Now, it was in the paper as a priority, but that wasn't translated into effective action in a country where this has become a concern, and which is a disease that doesn't discriminate by gender, by socioeconomic background, or age. So we actually decided to really chip in and to really make this not only a government's priority, but a state priority. Means that this will sustain, the efforts will sustain in time. Now, of these 50,000 cases a year that we have, about 3/4 are already detected in a very advanced stage, which tells you that there's an ample room really for early detection and for prevention purposes. So I think it's a good experience to take on and to learn lessons perhaps, and still it's a work in progress, because obviously things don't change in such a thing. So I'd like to convey to you 8 quick key ideas in less than in 5 minutes. Let's see if I'm able to do so. Again, I thank very much for the invitation. First, this is a costly preventing, advocating. It is something that needs public resources. And given this seminar, which is geared towards low-income countries or countries that have, regions that have, scarce resources, we needed to give this a priority in our budget. Our budget, as budgets are complicated to approve by Congress, as in here, the same as in Peru. But we decided to pursue about 7 years ago a concept which is a performance-based budgeting, which is you don't allocate budget, to buy vaccines and to pay for wages of doctors, physicians, but actually you finance the activities that will have a higher incidence towards a result, a product. In this case was the reduction of the incidence of the mortality from cancer-related diseases. So that was the objective. So you finance everything. So that changes really the chip of how you allocate resources beyond your usual input, output, but more towards a results-based budgeting process. So this is something, the first change in the way that we allocated resources. And we've actually tripled our resources. We've been a country that has benefited from a commodity windfall. A lot of revenues came into our country. So really making sure that the appropriate financial allocation was designed was essential. So that's number one. Number two is that we needed to prioritize and to have a gradual implementation for a program to be effective and to have an important impact. So working together with the experts, with our own National Cancer Institute and our health ministry and the finance ministry as peers in this endeavor, we identified 5 types of most chronic cancers in our country, namely breast cancer, cervical cancer, prostate, lung, and stomach, which were the 5 initial ones that we decided to prioritize. And to have a gradual implementation to be able to add other diseases on time. The third aspect is that in 5 years, I was in office 6 years, in 2 different governments, we were able to multiply by 10 the resources that were allocated towards this process, towards achieving this objective, which is different than just throwing in cash and paying wages. It's a different concept because this intends evaluation of the results of what you're doing. And in this case, information is essential. So in this program, what we did was not only to have a lot of information, to have baseline so we can evaluate the success upon the different interventions that were geared towards education primarily, diagnostic, treatment, etc. We thought that information for monitoring purposes, including this in our own annual national household surveys so that we could have the relevant information for appropriate policymaking and was essential. And this was done in many domains. This is just an example. A fourth area, so one is performance-based budgeting, second is a gradual approach, third is obviously budget allocation, fifth is these programs. The next item that I think is very important is that in countries, in emerging, developing countries, continuity and sustainability is really a very, very critical issue to sustain any efforts that you may take on, be them closing gaps in public services and of any kind. So what we decided to do is to approve a law, a very important law in our Congress that is very difficult to change because you need a majority, which means you need 2/3 of votes to that resources allocated to cancer prevention, early detection and treatment were intangible, meaning that there was no way you could reshuffle from one item to the other, one, and two, it went beyond the usual annual allocation. So our budget now is already insured from a couple of years ago till 2018, so as to give a commitment of the sustainability of the effort that the public sector can do, so as to sustain, this program and to really signal to the, to the society and to the international community and to the private sector that our government is taking this seriously. I mentioned information is key because for us, we tend to not only allocate resources, which are always insufficient, but we need to allocate them wisely, and we need to learn from what works and what doesn't work. And we have undertaken a series of evaluations year by year, trying to learn about ways in which how to improve, the activities to reach this goal of reducing the incidence of cancer. And in here, the initial impact of, we need a few years. So we did an impact a couple of years ago, done with our health ministry and with our National Cancer Institute equivalent. And we identified that we had positive results in terms of this monitoring effect. The training of the program was very important, not only for the physicians and healthcare providers, but for the general population. We invested in equipment that was necessary and having the appropriate profiling of patients. Lack of information again, which were the main results of this evaluation that we undertook and that we're doing constantly given the household surveys that are being performed in Peru every year. So the challenges, and with this I conclude, the challenges obviously are many. This is a disease that really is very, very costly. Therefore, prevention is a key word, and early detection. We actually have internalized that in our policy making, and hopefully for the governments to come, this will remain so. For this, actually, there's other challenges, but I think information is one, gathering the appropriate information. And here, actually, we have a shortage of specialized personnel. And for this, for instance, I'd like to highlight the fact that for educational purposes, for research purposes, we're trying to partner with different entities, one of which is a National Cancer Institute, Dr. Trimble and his team. We've been trying to make this Plan Esperanza, Plan Hope. That's what we call our cancer prevention program, really something that we can sustain over time, that we see results, and that we can really contribute to the discussion of public allocation, and something that is a goal, a priority of our government. So with this, I finalize my remarks. Thank you.
Thank you, Ambassador Castilla. It's certainly very refreshing to hear a former Minister of Finance who's so engaged in thinking about prioritizing for high-burden diseases like cancer. I'll turn to Loyce Pace, who is Executive Advisor of Programs and Policy at LIVESTRONG Foundation. And Loyce, it would be great to hear from you on particularly the patient perspective and how patients might be better engaged in the process of improving cancer services.
Sure. Thank you, Afsan. Hello, everyone. I think sitting at this workshop over the last day and a half, one thing that really stood out to me is how much so many of the presentations were person-centered, and I think that was really refreshing for a lot of us in the room. It reminds us that we need to start with people and start with patients themselves. And so some takeaways as we're giving opening remarks. One is around this idea of stigma that came through in a few presentations, and obviously it's something that we're aware of, but it's again, we need to know where to start and what we're dealing with when we're going into these settings. It really is at a basis a fundamental piece to advancing screening and early detection, prevention and early detection, but also really relates to treatment and support as well. And so one of the things that the foundation actually did, and this is getting back to Dr. Khalif's presentation on Jordan, is we really tried to get a sense of what the perceptions were around the world when it came to cancer. And it was really startling. About 10 years ago, we did man on the street interviews. We looked at what the media was reporting. And from Italy to India, you had the same things that we're hearing about. Cancer's a death sentence. It's caused by witchcraft. It's caused by being hit in the chest when you're a young girl. So everything that people shared really resonated with me. I'd like to say that this is shifting a bit. And so then in our work, we actually did try to implement pilots that showed how we could sort of move the needle on these perceptions. And we've seen that work in South Africa, in Mexico, and other parts of the world. And this is a toolkit that we have developed ourselves to try and pass along to others who want to try to shift that thinking too. And so if anyone is interested in talking more about that, I'm happy to provide that as a toolkit, because we need to definitely be sharing these resources so that, again, we can deal with this fundamental issue. Another part of that, though, and someone made this point in the presentation this morning, is it's not just about people's misperceptions, right, and myths. I mean, there's a reason people believe what they do, and it's because some of it is true. People are dying at greater rates of cancer in low-resource settings, and we do have to address that problem. And so coming back to how survivors can play a role, it's essential that we empower people to tell their stories, to drive screening and support for people who are affected by cancer or at risk for cancer. So I just wanted to make that point as well. It's, I think we have a tendency to say, oh, gosh, these backwards ideas, and sure, we can roll our eyes and say that these are things that couldn't possibly be true, but they have a basis in reality, and I wanted to remind us of that as well. Another way we meet people where they are is also by having this more systems focus, and I was really pleased to hear a lot of that as well, this idea of integrated holistic care. People are more than their diseases, obviously, and so the more we can focus on strengthening health systems and thinking holistically about how we approach all of this, that's essential. It's something that we talked about when testifying in front of the House Committee on Global Affairs, really pointing to work like that of Pink Ribbon, Red Ribbon, and also of Partners in Health, groups that really try to catch people when they come in the door. So they might be coming in for HIV screening or treatment, but they're leaving with an understanding of whether or not they have precancerous cells for cervical cancer or other risk factors for other non-communicable diseases. That's really important. And we can't, I understand, hang our hats on things like PEPFAR or some of these other platforms that have a lot to deal with already, and that's an important part of our discussion that we can maybe continue this morning. But leveraging those existing platforms and resources is going to be important, especially in a time of limited resources. I think finally, this idea of social determinants, again, not surprising, but the global cancer issue is bigger than everyone in this room, and people have referenced the new set of Millennium Development Goals, which are the global goals or their social development goals, which are really encouraging to see. Those are put in place and developed so that we can sort of try to develop solutions across our silos. So not just within the health sector, but also with economic issues, environmental issues, really looking outside of where we usually work to really try to address the problem. It's a universal equity agenda too, and so we're not just talking about poor countries, we're talking about countries like the US when we talk about the global goals. So I think those are my main takeaways, and I'm happy to contribute later.
Thank you, Loyce. I am really glad you brought up the point on the SDGs, because we've been very narrowed in our discussion, and I think it'd be important and valuable to take a step back and think about broader common cause platforms. So how can cancer fit into the universal health coverage agenda? And I would love to hear from the panelists, and particularly Ambassador Castilla, from a country perspective, what can be done in terms of meeting that. I think it's sub-goal 3.8 or something along those lines. And also, what targets can be established at the global, regional, and national levels for meeting the goal or target of reducing 1/3 of premature mortality from NCDs, which is fairly broad, and cancer fits into that, but what can we do?
Yes. No, I think the coverage is something that is essential. No, I think universal coverage in healthcare was one of the 17 of the new goals towards 2030 established at the UN. And this is something that actually needs to be done usually in an environment in countries where you have a formal economy living next to an informal economy. Because really the basis of most of the insurance coverage or old age pension coverage or whatever you name it has to do of how much of a formal economy you have, so that you have people that have the capability of contributing to some sort of insurance while they are working are doing so. And in a country such as mine, where we have 70% informality, is very difficult. and therefore the burden usually falls either on the family itself, in the first instance, and then eventually on the government. And the government has limited resources. We've actually we've gone a long way, because we actually about 10 years ago, it was a third that we had some sort of healthcare insurance, a third of the population. Now it's 2/3 in 10 years. So we've done, we've done strides, but still we have 10 million people out there. That is a lot of people, and to cover. So this means to be able to sustain this, governments need to chip in even more. And perhaps one needs to tackle the informality, have a broader tax base, more permanent revenues, so that you can finance such issues on the one hand. And on the other hand, work with the private sector through public-private partnerships. That is what we've done, not only for financing objectives, but also to be able to import best practices and more efficient management and the delivery of such services. So for a country such as mine, we're committed towards meeting these targets, and we're committed towards having universal healthcare coverage in our country. It means to tackle the informality issue, to have a broader, tax base of people that are able to contribute, and for those that aren't able, to have the government be effective in terms of delivering these services. And financing, once again, plays a key role. So this is one of the key areas in which we actually have, as a national goal, is to be able to get this even before 2030. Those 10 million people that still don't have access to such, healthcare insurance. Now, talking about cancer itself, it's actually even more complicated because it's a very costly disease. That's why we're trying to advocate for make more of an effort towards prevention and early detection, and to have transfers of know-how and from other parts of the world, such as with the U.S., for instance. But I think the universal coverage, it is a key issue that really goes beyond just ensuring everyone. It is the sustainability of such thing. It would be nothing worse than giving someone a service, that is, and then take it away. That'd be the worst thing you can do.
Dr. Trimble?
Yeah, I just want to emphasize the importance of, as universal health care does cover cancer care, to make sure that that cancer care is good cancer care. So we have to make sure that we build in the metrics for quality, because we don't want to be paying for bad care. And there are some terrific examples. I mean, in Chile, for example, they've got a great system for pediatric cancer, so that they've centralized cancer care for kids. Kids can only be treated at 4 hospitals in the country, and they have to be treated on standard protocols for their disease, or their care is not reimbursed. So there are some good examples, but we have to make sure that when people get care through universal health coverage, they get good care.
I just wanted to comment that of those 17 goals, universal health care coverage is the only one that's considering a non-communicable disease indicator. You always see HIV as well as maternal and child health. So if there's something that can push it forward to include cancer or other non-communicable diseases in the other 17 goals, that'd be great.
Dr. Brawley?
The ambassador speaks of an example of a country that's done very well and has had wisdom to organize itself. And the example actually makes me realize that economic improvement is actually incredibly important to healthcare improvement. And going beyond that, improving one's healthcare system in general is really important, not just one's cancer-specific healthcare system. And actually, your examples are amazingly good for bringing that forth, and I thank you for it.
Yeah, just a reminder of Tom's presentation from yesterday, right? And when you look at the CFR report, they really showed that poverty was a major driver for the rising rates of cancer across it. They were looking at low and middle income countries, but I think it could argue low resource settings across the board. And we have to really we have to get this message out. I mean, we have to make sure that policymakers or other decision makers really understand what the drivers are, because that's what's really, I think, limiting action in this space. There's resistance to really addressing the issue because there's this idea that they're, lifestyle or couch potato conditions. I've heard someone on the Hill refer to them as, and that's not the reality. The reality is these aren't just choices people are making. These are conditions in which people live, which are putting them in a state that creates greater risk for cancer and other issues. And so this idea of poverty really and development is essential. And again, we have to be thinking outside of health.
Right. I think that's critical. And I think a question that we're talking about action, which is important. What are the costs of inaction if we're not doing what we need to do? And I mean both monetary and non-monetary, the impact on families, on caregivers, on society.
I like to say you pay now or you pay later. I mean, take your pick. It's probably going to be more expensive later. And so you really do, health is an investment, and that's a framework that I know we struggle with in this country. But we'd really have to see it as an investment. And beyond the economic cost, which I think is another important point, you do have these societal costs. I mean, people are, cancer and a cancer diagnosis fully affects an individual, a family, in ways that I think we've all seen, right, beyond the pocketbook. And so I don't know the best way to communicate that as well, like those intangibles, but perhaps that can be part of our dialogue when we talk about costs. We say in the NCD community, you have to speak to the head, the heart, and the pocket. And so there's it's important to kind of think more broadly as well about how we communicate, the effect on people, I think.
Well, if I can just bring an example from the United States into play in my call for rational use of health care in all countries. In the United States, our irrationality has left us to the point where I was reading a paper just over the weekend. If the last 30 years of our healthcare economy predict the next 30 years of our healthcare economy, by 2035, the average cost of a health insurance policy in the United States for a family will be the same as the average family income in the United States. That's not that is, our economy is actually going to collapse before that happens, because that's impossible. But we desperately need, these are incredibly expensive interventions. They have to be an important part incorporated and integrated into the rest of a country's economy. And we have to start doing things in rational ways, doing the things that actually matter and are of economic value, and not doing the things that are a tremendous waste of money that sound right.
I have a question for Dr. Brawley. So, but value from whose perspective? I think you make an important point. I think the debate that we've been having, especially in this country, is who determines value.
Right.
In what I've been saying today in my rhetoric this morning, I'm actually talking about value from a public health perspective.
So as a health systems researcher, I'm inclined to push the point on health system strengthening. And what are untapped platforms that we need to leverage? What are the opportunities?
I think we heard from Peter this morning about the importance of using surgeons, making sure that surgeons are at the table. Obviously, that they can give chemotherapy. I mean, I was trained to do surgery and give chemotherapy. In some cases, the surgeons can help with the pathology, and so I think we've also heard yesterday about the importance of using nurses. We heard both yesterday and today about the importance of community health workers. So I mean, I think there are they're greatly there are resources out there that we can definitely tap into.
Don't forget the importance of preventing disease to begin with. There's still a lot of work to be done in smoking cessation. As I look to Asia, I see many countries where more than 50% of adults smoke cigarettes. As I look to Africa, I see countries that the tobacco companies see as places for growth and investment where they can sell more cigarettes in the near future. Don't forget the importance of diet and physical activity as a cause of cancer. In a number of Western European and North American countries, including Mexico, the combination of obesity, high caloric intake, and lack of physical activity is about to surpass tobacco as the leading cause of cancer. And if we go into certain countries in Africa, especially South Africa and Egypt and others, we see amazing increases in the obesity rate just in the last 10 to 15 years. So don't discount prevention while we're trying to build a system to actually treat disease. And when we start treating disease, I would actually go toward, pardon my use of the phrase, the low-hanging fruit. The cervical cancer, there's great interventions that we can do that are very inexpensive that will save lots of lives. Lots of young lives will be saved. And then there's some other things. The work that I saw presented today on colon cancer was just absolutely amazing. And perhaps we can focus on the things that will save the most lives.
I wanted to ask a question. Dr. Brawley brought up this very important point around strategic messaging and misinformation that's out there. And how can we better engage the media? And also thinking about social media in an effective way.
Well, some of it is actually we need to engage health professionals. You know, in this country, we've had people who've been advocating interventions that are not scientifically proven, or actually after years of doing them were scientifically proven to be wrong. I mean, both treatments as well as screening, and you can go back over the history of medicine and find lots of that. I think that we in medicine need to go back to scientific principles, talk about what it is we know, what it is we don't know, and what it is we believe, and label them accordingly. And then we need to be open and honest with both the news media as well as public health and political officials who actually get to determine where money is spent, so that money is spent in the wisest possible way.
I'm thinking about Tom's comment yesterday that he said he goes to the Hill and people haven't been hearing about this issue, and he challenged advocates actually to maybe be more aggressive and perhaps less apathetic. And I've had this conversation with Tom. I don't know if the problem is is that there's apathy or that there's miseducation. I think it is in the message and the messengers. We are not really being terribly consistent in what we say, and that's especially in the global cancer space. And I think Otis would say in general, and I do agree, we have to really focus on this low-hanging fruit and just continue to drive that point home. People, media, policymakers, the public are just confused, and it's not. We could really harness the power of social media, but instead I think it's added to a lot of this confusion because messages just sort of spin out of control. And without people like us to really help correct that consistently, it sort of gets out of hand, and we lose touch with reality. Everyone loses touch with reality. So I just would make a plea for us to not just speak, shout from the rooftops, but for us to do so in a way that we're holding hands. And it's just, the message is just way too fractured for people to be able to do anything about it. And so then that way they do nothing. I would also argue that we need more people, especially on the global side, folks who have traditionally worked in HIV/AIDS, who have worked in maternal and child health. I love cancer people. I've been working in cancer for a long time, but we are not powerful enough. We're not influential enough in some of these areas. And so if we can point to people who, are getting more of the money from the U.S. government, for example, to do other global health programs, I think those messengers can be more powerful. Or coming back to the poverty issue, if we have more people who are dealing, in low resource settings and working with folks and across other issues, talking about health, that could be more powerful.
I think one important issue is the education in general. I don't know how many textbooks for kids, really tell you about what cancer means. How, or in general, there is I think here perhaps, and in other countries, there is a lack of enough information about what this disease means and the potential it has to really create distress, not only in the person that is sick, but in the whole household, the whole family. And I think this goes towards a curricula and education, because if you're more educated, then you tend to go to learn more how to be able to mitigate, the potential causes of cancer. You tend to be better, do more physical activity, eat better, etc. And I think this goes really to the essence of how informed we are, is if we're educated enough, and we see this as something that can really touch any of us. And so I think education is critical, in any long-term policy towards reducing the incidence of cancer.
It's our responsibility also to train media. I think we don't, I think, do that in a consistent way. I promise one more question. Dr. Trimble, you mentioned use of mobile technology or mobile phones. What are the most exemplary, in your opinion, or promising technological solutions around cancer prevention?
Well, there's a whole host of things under development, as well as things that are already being put in place. I mean, there's some great examples of, for example, there's been some beautiful work in Bangladesh using text messaging to communicate with back and forth between nurse midwives and pregnant women. So so if a woman goes into labor, she texts the nurse midwife, who then knows to how she's doing. If she delivers safely at home, then the nurse midwife can schedule a visit to give the birth dose of hepatitis B and check to make sure the mother and baby is doing okay. If there are any problems in labor, then they know to send an ambulance to the house to take the person to a district hospital where they can have the appropriate obstetrical intervention. So I think there's we're looking at some to see whether we can look at cancer diagnostics that are linked to smartphones. So that there's a whole host of potential things that are out there that we're very excited about. But they need to be validated. They need to be integrated into the healthcare system.